So I think this is a talk little bit in sync with what Dr. Zahid said. So we have to be really taking care of the babies who are born early, and also some of the term babies who require our help. And that becomes the importance of golden hour for our both term as well as premature babies. So first of all, how to collaborate with the obstetrician and our parents. Parents, I will leave spoken so well, and obstetrician also to some extent it was in his talk. But the only thing what we should be talking to them about, like what we should be at sync with each other, and especially not to forget our babies would require antenatal steroids. They need magnesium sulfate and delayed cord clamping. So that thing, and some of the mothers would require antibiotics. So those things we have to talk to them in length. So why we are so much talking about golden hour during the resuscitation and beyond is, and as who was mentioning that we take most of our things from the adults, and that's how this golden hour came as well. And it was adopted from adult trauma, because when they felt that if you don't you manage your trauma patient within an hour appropriately, you are going to have a long term effect on them. Similarly is our babies. So we if we don't do that appropriately, we might have long term effect. And what does it include? It includes neonatal resuscitation. Along with that, it needs includes post resuscitation and transporting the sick babies to the your own unit or wherever, and to give us support during that whole time, the respiratory and the cardiovascular support, and initiate the things in nursery. So when we don't open, when we start resuscitating and we don't really touch the clock timer, we really, you will be surprised, you will not even know when these one hour has passed. And and you will see the obstetric team has left, everybody is left, and you are there alone in the delivery room with the patient. Oh, what happened? So already you are out of time. So that's uh, 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 and I would go ahead to say that for a premature baby, even the golden first minute is very, very important. So we need to look at that. So in that, what all are going to be including, we will include from the antenatal care to the delayed cord clamping, hypothermia prevention, using plastic bags, maintaining temperature, looking at the respiratory thing during the birth and later, not to use bags and try to use TP's resuscitator in your unit, and early CPAP. So every delivery room should have that facility. And then once you take the baby, so early caffeines and when to give surfactant. It is, I'm very loud actually. So TPN administration and antibiotics within the first hour. And don't forget about what Dr. Zahi said, like talking to the parents, talking to your own team, briefing, debriefing is very important for that time. So it is a very busy slide, but it is a very, very important slide where what you should be doing in minute to minute. So pre-delivery, you are going to review the maternal history, and you're talking to the family, and you're actually pulling out all your equipments, making sure everything is working, and temperature of the warmer is on, and also the temperature of the room is fine. So all these are in pre-delivery. And then 0 to 10 minutes, of course, there will be a leader who will be forming a team, and we'll be assessing the heart rate and respiration, and the other members would be putting the baby in the cling wrap and attaching the pulse oximeter and ECG. And the third one would be looking at the FiO2 requirement and going up and down as per the requirement of the baby. Within 10 to 15 minutes, you will be stabilizing this baby. And if God gives that time for us, that we stabilize within that time, we need to transport the baby and talk to the family member at the same time. 15 to 20 minutes, you have to insert the lines, and there should be second provider who should also be writing the because we don't want hypoglycemia. So what is the fluid? And one of us, if we have a facility of respiratory therapist, he will be looking into your respiratory ventilator requirements and will be putting those on. For us, we don't have that, and so we do it ourselves along with the nurses. And within 20 to 45 minutes, you will be starting your fluid. And if you have a pre-made TPN, you can start your TPN from there. And then 45 to 55 minutes, you will be doing an X-ray. And if you also need a surfactant, that has to be given. And 55 to 60 minutes, you will be sitting and again chatting with your family. So these are it's a big list, but I'm just giving you just that, how the timeline flows, and you should be not carried away and doing just one thing and forgetting the other things. And each one has a different role to play: the doctor, the nurse, the respiratory therapist, the second nurse, that assistant. So everyone should know their role so that there is no confusion and no chaos in the delivery room. And we should can have these kind of sheets available so that you are documenting, because everything cannot be just paperless, because some of the things in the NICU are still, for us, are with the paper, and we do use these sheets to document what we have done. So now coming to the each component, we will be talking of what would you be doing for the cord. And delayed cord clamping and the cord milking. So we all agree that we should be, and our NRP also suggests that at least 30 seconds of the time should be given for the cord to be delayed, to be clamped. And if more than 1 minute, it would be ideal if the baby is fine. um if it's not fine, then you I don't know, because now I've seen, and we are trying to procure that trolley where you can actually take the trolley towards the mom, and you can still do the delayed cord clamping and start the resuscitation. It's a bit costly, so we are debating, and we have our own set. We have done our own innovation by putting the those two air and oxygen cylinders, and we can have a battery backup, and we still take to the near the baby. Now, which position is safe, like whether we should be putting by the side of the baby mother, or should be below her? It's no evidence has actually said either of the two, but any of the two is fine, either there or just below. And the importance of, I'll just give one this slide by Satyan, who makes a nice cartoons to really understand that if you don't do the delayed cord clamping, and the baby's lung is still partially aerated, then what you will be devoid of giving this umbilical vein blood, which is containing air, which whose saturation is 80 to 85. I mean, to make it very simple. So even after 5 to 10 minutes, you will be the baby will be with that, and the baby is not good. So the saturation will still be uh, between 50 to 65. However, if you have delayed cord clamping, you have given the umbilical vein blood, which is containing so much of higher sats. So you will achieve this postductal saturation quite early on, even when you don't have a fully aerated blood. So that's a benefit. Other than, it's a big talk by itself, so I just wanted to say this. And for less than 28 weeks, I mean, if you're not able to do the delayed cord clamping, can you do cord milking or not? That's the question. So we were quite, and I myself had done a lot of cord milking to become, you start becoming more uh, overdoing things. And then we found that no, if you do those things, cord milking in a baby who is less than 28 weeker, you may land up in IVH, because you are actually giving blood with force. So the evidence says that, less than 28 weeks, don't do the cord milking. More than 28 weeks, you can, if you are not able to do the cord. So it came with evidence that 4 RCTs and 1 cohort about the cord milking, comparing the delayed cord clamping. There was no difference in rate of deaths or but there's no data on neurodevelopment, no difference of phototherapy, but definitely you have a more IVH when you do the cord milking. Yeah, so these are the data which shows severe IVH. So I would say not to do that. Then another thing, which is when you are seeing a baby and you are because whether I should resuscitate or not, depending on the heart rate, how do I assess the baby's heart rate? So we know that there are different auscultation. We have gone away from the palpation, so we all know that auscultation palpation is below the auscultation, and then pulse oximeter and ECG is better than the even auscultation. But the problem is with the pulse oximeter and ECG, it takes time to pick up. So you may actually land up in a false lower heart rate and start resuscitating a baby when it's not really required. So that has to be taken care of. Now, during that golden hour, what is the safe oxygen which you are going to be using? So everyone should have in their delivery room this chart where you are talking about the target saturation at different time, and this will work only when you have switch on the timer. So the timer should be on, and you should know that we are going to target this saturation. Having said that, what saturation, what FiO2 to start with? So it is not same for all the babies. Different gestation will have different FiO2 to begin with. So if we have a baby who is more than 35 weeks, we have good enough evidence that we should start 21%, because when we start with the higher FiO2s, we have a bad neurodevelopmental outcome compared to the 21%. So for every baby who's more than 35 weeks, we will start 21. What about the babies who are less than 35 weeks? It's still debatable. And actually for 28 to 35, it is between 21 to 30. And I don't like giving range because then people get, confused. So I say 30. And less than 28 weeks is also 30, but I'm sure in the next NRP or in the next few things it might come as 40, because it has been seen by studies in Australia that if you don't achieve 80%, 85% of saturation within 80% of saturation within 5 minutes of age, you have a bad outcome, which may be death, which may be neurodevelopment outcomes, so, and which may be BPT. So as per now, we will be continuing with 30. But I like, usually if it is 23, 24 weeker, I would prefer 24. Now, what about the delivery room CPAP? Why is it important? How is it feasible? What precautions are we going to take? And what are the precise indications to do that? So we all know that whenever your baby is born, the alveoli are collapsed, and even your airway is not that well. The smaller the baby, the chest wall compliance is also quite poor. So when you put a CPAP, it is going to reduce upper airway resistance. It is going to establish the functional residual capacity. It will decrease the chest wall distortion. And of course, it also helps in augmenting the baby to breathe by himself. Along with that, which so many support, COIN, and all those trials have shown that it preserves the surfactant. So the use of surfactant decreases, and the studies have very clearly shown that if you start the CPAP, the requirement of the surfactant is reduced by even for 24 weeker 30, it is reduced by 30%. So 70% of the babies would require surfactant, 30% of them would not require surfactant. Bigger the baby, more the effect is. And of course, it decreases the need of your mechanical ventilation. So you can see very well that your lungs are so much collapsed, and when you are putting the CPAP, it's inflated well. And so it is increasing the pharyngeal cross-sectional area, so decreases upper airway obstruction. Obstructive apneas are reduced because of that. And because of the functional residual capacity, your BPD rate is going to be less, and need of mechanical ventilation is less. But having said that, any thing you should, whatever you are using has its own side effects. So please be aware that too much of a CPAP, which is, you should know which baby require how much. You may cause pneumothorax, and if you don't put the OG tube in, you may cause abdominal distension. If too much of CPAP is given, then you may have actually have an impact on the pulmonary blood flow, and so it may actually cause more of pulmonary pressures being higher, PPHN requirement goes higher. So and another problem which is coming is nasal trauma. So we have to take care of these. So what are the scores which you can use to actually see whether your baby is in distress and how much in distress? There are Downey score and a Silverman score. If some of us are using, some of them have given it thrown the door out. So it depends. I mean, if you want, you can still use it. I feel it's like for the nurses, it's really a good way to understand it. So whether I can use, because you said so many problems with CPAP, so can I use HHFNC during the delivery room or not? So, it's very clear that if a baby who is less than 28 weeker in the delivery room as a first line, no. Even when you are post extubation, to put a baby on HHFNC rather than CPAP or a NIPPV, it is questionable and it has a lower efficacy. More than 28 weekers post extubation, yes, you can put, but as a primary mode, in even in the delivery room, HHFNC has not been shown to be thing. So you have to be giving some caution when you use this HHFNC. However, I'm a real fan of HHFNC and I do try to use HHFNC as much as possible. So it is from baby to baby. And we see that the effect, I don't want to, because of the time constraint, the reason why high HHFNC works by that main thing is that it causes a physiological dead space washout. So carbon dioxide washes out, gives a positive anti-expiratory pressure, reduces the airway resistance, decreases the respiratory rate, and increases the tidal volume and increase end expiratory volume. And don't forget the heated part, because the heated part reduces the respiratory workload, bronchoconstriction, increases the ciliary clearance, and hydrates the mucosa. So it's very important to use a proper HHFNC. Meconium strain liquor has come up as a very, very controversial topic. And we know we started from the squeezing the chest, not allowing the babies to cry, to, do the suction, putting the tube in. And I was part of that era. I had already given my presentation, so I have not put that. But there is a meta-analysis which is released on 8th of February on this topic, where my my colleague Dr. Sushma and Dr. Satyan, they did the meta-analysis, and they have taken 13 observational studies to include this meconium strained liquor and vigorous versus non-vigorous baby to do the suction or not. Then they have found 13 observational studies. They did find that uh, there was a benefit if you suction the baby to some extent, that, they will be less going into ECMO. There was a little more the babies who were not suction getting into respiratory distress and requiring some mechanical ventilation, but that was not really significant. So there was a trend towards that. So that's why they came up with the conclusion that you need to have more rigorous randomized controlled trial to do that. And Dr. Satyan, when he was here, he wanted to do that trial, and he was asking question, am I ethically right to do those trials or not right? So till we don't have, we say that though weak recommendation, but that's what we are going to follow, that we are not going to suction even if the baby is non-vigorous. So now, when would you give epinephrine and how would you give? So we will be giving epinephrine to babies whose heart rate is still less than 60 beats per minute when you have done effective bag and mask ventilation, including MR SOPA, and you're done the right way. The new thing is that your epinephrine is the dose which I never like this range, because people are confused, So now they're trying to come out of the ranges. So earlier it was 0.021 to 0.03. Now it is very specific 0.02 ml per kg, 1 is to 10,000. And the first dose should be given in 4 to 5 minutes. Tracheal one is to be avoided. Try to put umbilical line so that it goes faster. And if you are not able to, then you can get tracheal first dose. That is 0.1 mg per kg. And if you have inserted the line, give it and don't treat the tracheal dose as the first dose. So that's the recommendation. And so if you're not able to put a umbilical line, you can also put an intraosseous line. That's another thing which can be done in the delivery room itself. So are there any other changes recommended? So as we said, we have already talked about few of the changes, but the room temperature, actually, if you are going to have a smaller baby, they are recommending not 23, 24, they are telling 25 to 26. So that is a new thing. Less than 32 weeks, you should have a polyethylene plastic bag, wrap, thermal mattress, and you should be going for a if you want to ventilate, you should have PEEP and PIP both. However, how you give TPs or a AMBU with the PIP and PEEP available, and you should have a CPAP. Should be giving to those babies who are breathing spontaneously, but they have a labored respiration or a lower oxygen saturation. And handle the baby gently to avoid positioning the. So you should have a head and up and the legs down. What if the baby is actually having a need of a chest compression? Then how much FiO2 to be given? So you should start 100% FiO2 for those babies, because it is seen that when you start 100% oxygen to those babies who are requiring chest compression, your oxygen delivery to the brain is going to be better, and your PO2 is going to be better. So you should be starting 100% immediately. So this is the chart to talk about that how many weaker, as we already talked about, to start 21 and 30 on the bigger babies. They should achieve FiO2 5 minutes, 80 to 85%. And if ROSC has already occurred, then you should start weaning the FiO2. For term babies, you should try to come down to 21. And if you have a diseased lung, you can go up to come down up to 30 to 40. And again, if you require chest compression, go to 100. So how do you prepare, give normothermia? Theater temperature, as I said, smaller baby, the higher the temperature, pre-warm the linen, pre-warm hat, and avoid draughts of air. So if you're making your delivery room resuscitation area, please don't make it near the uh, near the door where people are opening, coming down out and bringing draughts of air. No drying, plastic bag to be used, heated mattress and overhead warmer whenever required. And whenever you're doing any procedure, try to or you should have a incubator which can be converted into a warmer, the giraffe or the thing. And minimal handling and humidity. Sepsis part I will skip because she took a session on the GBS and thing, my last speaker. So I'll skip this. You can, I think there's a time limit. So 2 minutes. So you can actually take this slide, which is really important, whom you will be doing investigations and whom you're going to straight away start the antibiotics. So surfactant, we all know that whether I should give prophylactic surfactant or rescue surfactant, I would go for a rescue surfactant. I don't believe in any prophylactic treatment. And we have to I follow the European guidelines to give the surfactant, which means if the baby is already intubated or if the baby is on CPAP and you have given adequate CPAP and the FI2 requirement is more than 30%, then you have to give surfactant. So you to give 200 mg per kg, and for this, don't wait for your X-ray because you know that the baby is distressed and small baby, and don't waste time. So early is always better. And which surfactant to be given? So animal derived surfactant is better till now than the surfactant which is artificial. And when to give, we already talked about. Which surfactant to give? I believe in procactin, because of the fact that lesser volume. Zahir might differ from me, I know. Lesser volume and more concentration we can give, and avoid the second dose. So 200 mg per kg is always better than 100 mg per kg. You will also not believe, no problem. We have enough evidence. And then how to give Lisa. So I thought only Zahir is part of the non. No, we have the Curacao. So we are using 200 mg per. So we are talking about not ml. We are talking about milligram per kg. So 200 milligram per kg. Yeah, yeah. So I'm not talking about volume. So I'm saying I'm not talking about volume. I'm talking about if I'm able to give 200 mg per kg. Yeah. So 200 is, I'm talking about milligram. Yeah, yeah, yeah. So 200 mg per kg is better than 100 mg per kg. So that is thing. And Lisa is better than the intubation. So TPN we should start early. I don't want to go into that. And this is very important, the IVH bundle. Please and please, if you're taking care of the small babies, put into your checklist about the IVH bundle, and every nurse, every doctor, they should be knowing about it, which is a big list. I don't want to go through the whole because he's already standing by my side to tell me to stop. Um, the other thing which I want to is kangaroo mother care and mother's own milk. Yeah, okay, thank you. So kangaroo mother care, mother's own milk, I would say, which should be the first priority, even if you're it's a drop and you are actually doing a mouth like uh, yeah. So yeah, that's also important. And our units are ready for are your unit ready or not about kangaroo mother care? And I believe in zero separation. So we try to have a zero separation. So we should have a mother friendly NICU. We have been able to get only one room like that, but I think some of the hospitals have more rooms where the mothers and the babies stay together. So you should take the mothers, parents with whenever you're taking any rounds or doing anything, and it gives a better long-term outcome and better maternal health. So this is the NRP which you can do, and these are the timelines when you can do whatever, and everything has to finish. You should have with you golden hour sheet, admission note, central line sheet, vital sign sheet, verbal and written consent record, ventilation record, order sheet, admission list, entry part of the discharge summary sheet, and hypothermia assessment sheet. All these should be there in the unit and filled and kept. Thank you very much.